Assalamualaikum and good evening. My name is Muhammad Nur Akmal bin Mustafa, undergraduate student OUM for Bachelor of Medical and Health Science. Today, I will present about the management of a pre-hospital care for a patient with polytrauma. I will start my presentation with an introduction about polytrauma, the definition of polytrauma, and present a case study based on my experience regarding polytrauma. According to data from the World Health Organization, WHO, and the Center for Disease Control and Prevention (CDC), more than 9 people die every minute as a result of a traumatic event, and 5,800 million people of all ages and social classes die each year as a result of intentional or unintentional lesion. According to O'Connell et al., 2018, traumatic traumas account for 12% of all disorders worldwide. Polytrauma was characterized as a syndrome of several injuries above a set severity injuries, severity score ISS above 17, with successive systemic traumatic reaction that may cause malfunction or failure of distant organ and essential system that were not physically affected, or patient with any one of the following combination injuries: 2 major system injury plus 1 major limb injury, 1 major system injury plus 2 major limb injury, 1 major system injury plus 1 open-grade third skeletal injury, unstable pelvis fractures with associated visceral injury. Polytrauma included many bodily areas being wounded, which not only impair the patient's physical health but also has the potential to produce organ dysfunction. In intact organ, individuals with polytrauma have a higher risk of morbidity and mortality than those who have just received a single injury because of their multiple trauma. Physical, cognitive, psychological, behavioral, and functional impairment, as well as disability, are frequent after polytrauma injuries. As a result, managing a patient with polytrauma necessitates highly focused expert care and a multidisciplinary team approach, as well as significant rehabilitation and maybe a surgery. Now, in this case study, the patient name is Mr. X. His gender is male, age 19 years old. He is Malay college student, guy, and still single. Moving on, Mr. X, a 19 years old, riding a motorbike, wearing a helmet, was on the way to his friend's house when a very high-speed car hit him when he was crossing the traffic light. He eventually lost control and fell from the bike. Upon trauma, he was complaining of pain over right hip, shortness of breath, tenderness of his left chest. He was then brought to the emergency department. Upon examination, his airway is clear. Cervical spine immobilization after next examination with no major abnormalities. His reading for respiratory rate 20 per minute, reduced air entry over the right side, asymmetrical chest, SpO2 18.5% on room air. For circulation examination, his vital sign shows blood pressure 94/58, heart rate 137, pulse 88, heart sound arrhythmic regular beating, no extra heart sound, no splitting of heart sound, snaps, clicking or murmur noted. For disability examination, Glasgow Coma Scale, I4, verbal 5, motor 6, both people reactive bilaterally. For his exposure examination, puncture wound 2 x 1 cm over left elbow and 2 x 1 cm over left mid-shin. Abrasion wound over left knee, deformity over right thigh, DPA, TPA palpable, able to move all toes. Upon his arrival to emergency department, it is necessary to assess his condition using these two types of assessment or survey. 1. Primary survey and resuscitation, identification of life-threatening condition, ABCDE approach. 2. Secondary survey detailed head-to-toe examination, medical history, all lab and radiology investigation ordered, management plan. The purpose of initial assessment is to identify life-threatening emergencies, to identify the need to access, change, reassess, to identify the need to initiate life-saving measure, CPR, Okay, here are the importance of indication for primary assessment. Patient is conscious or not, airway, ventilation, sign of massive external hemorrhage, there is any deformity, skin colors, temperature with feeling pulse. Primary survey involves assessment of airway, cervical spine control, breathing, circulation, disability, neurological, exposed. Okay. A well-organized disciplinary trauma team is best suited to handle polytrauma. If a trauma team is available, these steps can be completed by various members of the team at the same time until the spine has been cleared according to local rules. The neck and spine must be protected. Assessing airway. The assessment of airway is important to see if patient require intubation. Intubation is needed if inadequate ventilation and oxygenation, impending actual airway, obstruction secondary to injury, brain injury with Glasgow coma scale less than inability to adequate to protect airway from aspiration. The ventilation support must be intervened with this method. Jaw thrust versus health tube. Deliver oxygen mask with reservoir. Use rigid suction. Secure the airway. Cervical spine must be stabilized by placing hands on either side of the head. Maintain neck midline. Manual inline stabilization. The aim of breathing and ventilation are to support if inadequate, to eliminate any immediate life-threatening thoracic condition. During the primary survey, we seek and treat any immediately life-threatening chest injury that will prevent proper ventilation, such as tension pneumothorax, open pneumothorax, massive hemothorax, or flare chest. It is critical to get a chest pelvis radiological exam as soon as possible. Excessive pelvic movement should be avoided since it can be dislodge blood clot from pelvic fractures and exacerbate bleeding. Pelvic binders are increasingly widely used to spin the pelvis, but a simple belt or tight bed sheet could suffice unless there is extensive hemorrhage from pelvic open or multiple long bone fracture. Bone injury are rarely fatal. External hemorrhaging should be controlled by packing the wound on exerting direct pressure. Early splintage, which restrict mobility and allow clots to form, can help to decrease hemorrhaging from fractures. Example of fatal chest condition are tension pneumothorax, open chest trauma, cardiac tamponade, flail chest, massive hemothorax. As for circulatory assessment, it is vital to assess carotid, pulse absent or present, capillary refill, skin color, skin temperature, site of bleeding. The intervention needed for circulatory assessment if central pulse is absent. Begin CPR. Apply direct pressure to open wound. Start IV access. 2 white bore cannula, 14 or 60 G, fluid colloid versus crystalloid, 20 ml per kg. Take into note to which one is more appropriate, peripheral versus central line. Dysfunction of CNS must also be assessed. For example, rapid neurological assessment to check for alertness, voice, pain, and unresponsive, dilatation of pupil, mini neurological assessment DCS, AVPU, pupil, lateralizing sign, blood sugar level. The aim for exposure assessment are to remove clothing, to allow examination for entire patient, to provide care when removing tight trousers, to prevent hypothermia, to preserve patient dignity, to remove spine board. The well-practiced trauma team should aim to complete the primary survey in less than 10 minutes. As for the radiology management of polytrauma, once the patient is stabilized, the patient is sent to radiology for the survey cervical spine X-ray, epi and lateral view, chest X-ray, rib cage, pelvis X-ray, abdomen and pelvis ultrasound. CT band is ordered if there is suspicion of a head trauma. X-ray of extremities if fracture is suspected. Mr. X radiological findings are right 8 to 11 rib fractures with pneumothorax with lung collapse, X-ray right humerus, chip fracture of a distal upper third with retained foreign body, X-ray left humerus, olecranon process fracture, X-ray pelvis left superior pubic rami fracture, X-ray right femur, closed comminuted fracture mid-shaft right femur. This is some of the X-ray image that was seen. X-ray chest, X-ray left humerus, X-ray right humerus, X-ray right femur, X-ray pelvis. Okay. Nurses' intervention are required in management of polytrauma to avoid risk of fall. The intervention are 1. Follow the instruction for backrest or limb rest. Joints above and below the fracture site should be supported, especially when moving or turning. 2. Place the patient on the orthopedic bed or secure a bedboard under the mattress. Pillow or folded blanket can be used to support the fracture location. 4. When turning, make sure you have enough people when rotating a patient in a spica cast. Avoid utilizing an abduction bar. 5. Examine and evaluate the splintered extremity for edema resolution. 6. Maintain traction position or integrity. 7. Double check that all the clamps in working order. Check ropes for fraying and lubricate pulleys adhesive tape if used to secure and wrap knot. 8. Assist with the installation of lift under the back wheel if necessary. 9. Place the patient in such a way that it requires pull on the long axis of the bone maintained. 10. Go over any follow-up or serial X-ray. Intervention of impaired physical mobility are 1. Determine the exact of mortality caused by the injury or treatment as well as the patient's sense of immobility. 2. Evaluate the patient's health literacy culture. 3. Listening for bowel sound after resuming activities. Check your blood pressure, BP. Keep an eye for the report of dizziness. To avoid risk for infection, 1. Look for any previous irritation or breaks in the skin continuity. 2. Examine the pin site and surrounding skin knotting. Any increasing pain, burning sensation, edema, erythema, bad odor, or drainage. 3. Examine muscle tone, reflex, and speaking abilities. 4. Look for bullae, crepitation, bronzer coloring of the skin, unfaulty or fruity smelling discharge in wound. 5. Wrap plastic wrap around the borders of the perineal cast. 6. Explain the patient that he or she should not touch the incision site. 7. Look into the onset of discomfort and movement restriction in the damaged extremities, as well as regional edema and erythema. 8. Keep an eye, patient vital sign, chills, fever, malaise, and changes in mentation should all be noted. 9. Keep track of laboratory and diagnostic tests. In conclusion, all trauma patients should be assessed using the universal ABCDE approach. Management of polytrauma should include primary and secondary survey. Teamwork is standard in management of trauma. Patient including nurses, MA, routine investigation should be implemented as a protocol. With that, I end my presentation. Thank you.